a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. We're here this evening with my co-host, Dr. Jim York. But we're here with Dr. Michael Hanus. He's a radiation oncologist with 21st Century Oncology.
Thank you for having me.
And we're here to talk about dermatological oncology?
Skin cancers.
Okay.
Before we get into that, Dr. Hanus, could you just give us a little background of yourself, where you went to school, and how long you've been here in Naples?
Yes, I'm a Midwesterner, grew up pretty much up in Kansas, and so I have an undergraduate degree in electrical engineering with a subspecialty in biomedical engineering. That kind of leads into my field of radiation oncology, where it's a very fascinating three-dimensional and even now four-dimensional, we control for motion field. I went to medical school at the University of Kansas in Kansas City. It's a very big researching school, and it's actually ranked in the top 10 medical schools in the country for about the last decade running. I was lucky enough to do my residency at the largest cancer center on the face of this planet, MD Anderson Cancer Center in Houston, Texas. And ever since Houston, since being Midwestern and liking warm weather, we decided to relocate to Florida, and I've been here for 11 years.
11 years, and your offices are located, and where you're located?
We have 6 offices in the Bonita, Naples, Collier County region. We have one of them in the Commons, one of them in front of NCH Hospital. We have a new facility opening next week that's on Collier Boulevard and basically 951 down by the new Physicians Regional Hospital. I have one up on Immokalee Road, and we have an office in Bonita. We're part of a big group that also has offices all the way up this coast. We're based out of Fort Myers, and so we have over 100 offices nationwide. Wow. And actually international presence.
Do you, in your offices in Collier County, are you providing the same services in each office?
Pretty much for most of what we do, all of our offices, the machines are to the level where you can pretty much treat anything. The actual specific devices I'm going to be talking about today is located in our office in the Commons. This is a live source of radiation, and since 9/11, the government really scrutinizes who gets to use or have live sources. So there's a special vault built that controls these. It's very tightly regulated through federal regulations. So in this region, pretty much all these treatments would be done in the Commons.
And I guess we're here to talk about skin cancer this evening?
Yeah, skin cancer is a big thing. When I was coming out of medical school, they were estimating there was about 1 million cases a year, and since we're coming into the phase where the largest segment of the population, the baby boomers, are coming into the years where they need health care. And you'll see they currently estimate skin cancers to be 1 out of every 3 cancers diagnosed is either a basal cell or a squamous cell skin cancer. There's over 3 million cases diagnosed yearly. And most people do not know that there is a non-surgical, non-invasive, incisionless treatment for skin cancers. We have treated in this country, radiation's been a dominant modality to treat skin cancers since the early 60s. With the progression of computer technology as well as other technologies, we have increased the ability to treat it where it gets as easy as 10 3-minute sessions, incisionless and scarless. So the field has advanced dramatically. The reason we're doing talks like this is for public education and public awareness. I treat a lot of skin cancers on a routine basis, probably 4 to 6 a day, every day. And these patients coming in have never been heard that radiation is a modality that can treat this. And so we're really trying to get just public awareness that if you do not want to be cut on or other cosmetic issues, and there's other things that we'll get into of why you use radiation versus surgery, we want to get public awareness that there is another alternative versus surgery.
There are many misconceptions on the part of our viewers and people in general about radiation, and people are afraid and they don't understand what it is. So can you give us an idea, or our viewers an idea,
of what it is.
Yes.
And I get this a lot. Radiation is a scary term, and people have been scared of radiation. And to be honest with you, through the 60s and 70s, we used live sources like cobalt, and technology just wasn't there. So to treat tumors, we couldn't even see them. You treated large volumes, and you ended up causing a lot of toxicity to normal tissues. And that's where people's relatives or their father was treated, and they remember they were burned and things like that. Since computer power has just skyrocketed, computers control our machines. We now have the ability to control time and space. We can pinpoint lesions millimeters off of very critical structures and not even bother those normal structures. So I wish I could take credit myself for all these advances, but it's really the advances in computer technology that allow these machines to just treat normal tissues, but literally within millimeters around those normal tissues, spare them. We have progressed so far in our treatment that we can treat a tumor to exceptionally high doses, higher doses than we could do 5 years ago, 7 years ago, and actually have much less side effects. We're not treating these normal tissues. So people can go through treatment, they're not sick, it's a real treatment, so they get a little bit fatigue and things like this. But the toxicities and the sickness and the long-term side effects we used to cause in yesteryear are pretty much ablated now. We don't even see those. And it again is all related to treatment planning. As all modalities have increased, imaging, mainly MRIs, CAT scans, PET imaging, it has allowed us to more isolate and localize where we treat. These machines now will treat in 360 degrees, where they come in with thousands of beams, pencil beams of radiation. These are 5 by 5 millimeter beams that are modulated in intensity depending on the thickness of what you're going through. So you can see that with the increase of technology and investing in these technologies, these aren't cheap machines. They're about $4 million machines. I've been here 11 years in Naples. Typically, when I was in training, a hospital system would buy a machine once every 2 decades. I've been here 11 years. We're on our seventh generation machine. That's how fast this technology keeps improving. And really what it does is allow us to treat to higher doses, which is much better local control. Our cure rates are a lot higher than what they used to, with dramatically less side effects. Because we're no longer including these normal tissues that we had to include because you didn't know where the tumor was. We couldn't localize it. So we have tracking systems that will track live tumors as they move. And I have a tracking system for prostate cancer, which we're not talking about, but it will track this within 3 millimeters. So if the beam is on and you're treating and your prostate ends up moving, you cough, you sneeze, or pass gas, which happens, and it moves out of the field, the beam's off. As soon as it comes back in within tolerance, it's on. So you get these foolproof systems now that can isolate the tumor, and again, it's protecting normal tissues. That allows us, our limitations in the past were normal tissue tolerances. We couldn't get the dose to where we needed to without damaging the surrounding structures. In modern times, with these kind of technologies, we can escalate that dose. We treat to much higher doses than we could previously, and again, that translates into higher cure rates with much less side effects.
Do you start off with lower doses, depending on, I guess, how far the cancer is gone or how big the tumor is, and then you build up, or
doses
do you start?
Are kind of depending on the tumor cell you're treating. There are certain tumors, like we call them liquid tumors, lymphomas, myelomas, that are ultra-sensitive, and so we use very low doses. In children, you're treating 8 to 10 treatments. That's it. But solid tumors like a prostate, that's about 9 weeks of daily treatment. So it depends on the tumor cell you're treating, and it also depends on what we're treating. If there's gross disease there, which means that tumor was not able to be removed and it's physically there, you have to use higher doses than when it's surgically removed, but I'm treating the draining lymph nodes and I'm treating the operative bed just to assure ourselves that there aren't any cells that we can't see. You can't see, these are microscopic cells. You can't see them on imaging, you can't see them anywhere, but there's a theoretical risk of a certain percentage that we justify treatment in, and that's what it's sterilizing. So when I treat a lot of breast cancer also, and in those women, they don't have gross disease. They're surgically rendered clear of cancer before they ever get to me. So those doses are a moderate level. Cancers that are left in there, say an unresectable lung cancer, those are treated to high doses because you need the high doses to sterilize the tumor.
All right.
And radiation is a very dominant modality. There's 3 modalities you use to treat cancers: surgery, radiation, and chemotherapy, or medical oncology. Surgery and radiation are very much the dominant modalities. Most people's cure rates are going to depend on what's the chances of these cancers spreading. And that's really dependent on chemotherapy, which has a much harder job than I do. If we can treat to high enough doses, there's not really a tumor that radiation won't sterilize or take care of. That's a different effect than these cancer cells that keep mutating and changing, and they're trying to treat it with a drug that has to have a target. A lot of times those in-body targets change or move, or they're not there. And that's why chemotherapy has the much higher, is a harder job to do versus radiation. Radiation is more analogous to surgery than it is to systemic. And we do it together.
You do, that's what I was going to ask.
Over the last 10 to 15 years, the major progress has been adding chemotherapy along with radiation therapy. It's called a synergistic response. If 1 + 1 = 2, 1 being radiation, 1 being chemotherapy, depending on what chemo they use, that ratio can be 2.5 to 3.5. And so you really get more bang out of the same buck, so to speak, by adding that. We couldn't do that in yesteryear. With these old-fashioned treatment technologies, we treated big spaces, big volumes. You couldn't localize the cancer. Imaging couldn't even see it. We knew where it roughly was, and that's why we caused so much toxicity. With modern treatment, we can localize it literally to millimeters. So you keep your treatment fields very tight. You only treat the disease process that you need to, protecting the surrounding cells. That allows us to escalate the treatment, not only in radiation dose, but also adding extra modifiers, chemotherapy. There's other biological modifiers that make radiation more potent, so to speak. And so that's been the major advances since computer power has allowed us to localize these more. We can just, again, escalate the dose and reduce side effects with better cure rates.
I know there's always been a question can you have surgery, can you have radiation then have surgery, or does it depend on the cancer?
There are certain tumors that we routinely treat preoperatively
to
sterilize the margins, to sterilize the liver, so that the surgeon doesn't have to do as big of a job. The primary one is rectal cancer. That is something where prior to doing preoperative treatment, these were big surgeries. They a lot of times had to do colostomies. Right. And most rectal cancers, when we treat them preoperatively to what I would consider a middle-level dose, about 1/3 of those cancers are gone when the surgeon goes and operates about a month later, physically gone. Depending on what disease site, and again, evidence-based medicine has worked us over the last 20, 30 years to say, for what disease we're treating, what is the optimal approach? And obviously, it's very individualized for each person.
So you're using the term, for the benefit of our viewers, sterilize, which most people would assume we're talking about killing bacteria or something. You mean sterilize by killing?
Cancer cells. Okay. By eliminating those cancer cells. And in the field, radiation, again, is like surgery, so it's a local thing. Whatever's in that beam, it will sterilize. It does not treat the whole body. That's why we have to combine it with a whole body treatment like chemotherapy. Chemotherapy they give in the bloodstream. Right. Wherever the blood goes, these tumor cells can float. Even if we can't see them, depending on what type of cancer we're dealing with, there's a risk of what's the chances of it showing up. And so that's why when you can combine them both, you're really treating the local area very aggressively, but you're also treating the rest of the body. So that is what's translated into higher cure rates.
You also alluded to markers that you could aid in increasing your beam dose to an area, biological markers. What do you mean by that?
Well, cancer cells will have receptors on them, and these receptors function in that cell, whether it functions for nutrition, whether it functions to turn the cell on to, say, divide. And there are either chemotherapies will attack these receptors, which makes that cell vulnerable, so that when you have the same dose of radiation, it's more effective because the cancer cell is already weakened, so to speak. There are biological modifiers that we loop into the chemotherapy world. They're not truly chemotherapy because it's really only hitting the cell that has that receptor. Head and neck cancers, there's a receptor on squamous cells called C225. And we have a drug that just hits that receptor, turns that receptor off so that that cell is weakened, and then for the same amount of treatment, our treatment is more potent. We've already weakened the cell. And so that's been the big advance in the medical oncology or the chemotherapy world over the last, say, 10 to 15 years is these modifiers to make treatments more potent without making the side effects more potent. They're more specific.
And do you also use physical items to focus beams internally other than, I mean, you're talking about external beam radiation.
External beam radiation has gotten so high-end that these machines actually have CAT scans built into them. So we place a patient in a mold. So they're in a reproducible, every day in, day out location. And so you line them up to in the mold, like a hand does in a well glove, so you're not tilted, turned, rotated. They have marks placed on their body that, again, straightens them, makes sure that they're in exact position. These machines will rotate around them, and it will actually see it so that you can see here's where you're supposed to be, here's where you are. Without even going in, you toggle on so that you're right on. When we're right on, we're under 2 millimeters off. Then you deliver the treatment. So as you're delivering it, you can see that you're hitting the target every time, and you know that you're treating the right area and protecting the normal structures around it.
Well, we're going to take a short break,
Okay.
and we'll be back.
And we'll talk about skin cancer.
Okay, and we'll be back to talk about skin cancer and radiation for skin cancer in just a few moments.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. We are here once again with Dr. Michael Hanus. He's a radiation oncologist with 21st Century Oncology. And we're talking about, well, we've been talking about radiation therapy in general, but now we're going to talk more in detail about radiation therapy for skin cancer.
And I'd like to talk to you about a new novel system that we use. Most patients, well, one, skin cancer is a very prevalent disease. And as our baby boomers get up there, it's becoming more and more prevalent. And most people do not understand that there is a non-surgical, incisionless, scarless approach to treat this. Radiation is that modality. Old-fashioned radiation used to, again, treat lots of normal tissues, and so you could cause scarring and hypopigmentation. I want to talk about a new system. This is called high-dose rate skin cancer or treatment. And basically what this is this is a system that will collimate the radiation and very tightly control it to treat just where we want. We have numerous applicators. We have applicators that are down to 1 centimeter in size. We have 2 centimeter, 3 centimeter. We can create custom molds for certain areas of the body that may not, these applicators fit on. So really what happens is the optimal patient for this, and the patients we see in Southwest Florida are patients where really cosmetically they would rather not have any sort of surgical procedure. Head and neck is the epitome of that. Right. Nose, ears, eyelids, lips, all that can be treated non-invasively, non-surgically, where you do not get scarring. We're through history, and the dominant modality to treat these in this cancer has been surgery. We now have Mohs surgery, where it's a more limited surgery, leaves less of a cosmetic issue, but then it's a lot of times that you'll have to get a plastic surgeon with skin grafts. This eliminates all that. So the areas I really treat are head, neck, and face for cosmetic reasons. And then the other big area in our aging population, especially in Southwest Florida, is on the anterior surface of their lower legs. That's for wound healing problems, people that are diabetics, people that are on chronic blood thinners, congestive heart failure where they have edema and swelling. There are some patients that just anytime you cut into them, they get an infection afterwards. This is a non-invasive way to take care of that without getting risks. Again, we've treated skin cancer since the 60s. Our results are just as good as any surgical results. To treat any typical skin cancer, you look at evidence-based medicine, the cure rate's 95+%, 95, 98. It's just a different modality to do it. Patients need to have a diagnosis of skin cancer before they see me. So they typically see their normal dermatologist. If they have a basal cell or a squamous cell cancer, these modalities are good really anywhere in the body. Where radiation comes to be a clear advantage, again, is for cosmetic issues on the face as well as wound healing issues on your leg. I do treat areas on other areas of the body, arms, that, where people just don't want to be cut into because they're on chronic blood thinners. But if it's something on the arm or on the back and you have plenty of skin and you're not worried about the incision, surgery is a one-day treatment. It's easier, it's more convenient, you can be done. Radiation, it's a little bit dragged out, but with this system, you can do it as low as 10 3-minute sessions. Patients tolerate it well. Really what they do is they come into a specialized room that we have in the Commons. There's a little pig that houses a live source of radiation. It's embedded on a wire. That wire is actually connected to one of these applicators. This applicator is actually placed on the lesion. The wire is connected to this. The computer, a little robot, will run it to a specific position in here and hold it for a very precise time. This right here is one of the FDA's most accurate medical devices. It's accurate to 1/10 of a millimeter in space and 1/10 of a second in time. So it's a very precise delivery of radiation. Because of the way it's built, it is collimated. So the source sits there, it scatters in here, and it literally will treat only 3 millimeters depth. That is how we can treat the skin cancers. Most of these skin cancers are well less than a millimeter. They're 0.5 millimeters, 0.7 millimeters, and that's pretty deep cancer. So these will easily treat that without destroying the underlying basal cells. So that's how you get a very mild to moderate brisk erythema, which means a very mild to moderate sunburn that will just dry peel in the healing phase in about 2 weeks with lotion, but it heals uneventfully. There's no scarring, there's no loss of pigmentation, and because we're treating a very confined site, with this I'm treating really the thickness of about a nickel in that patient. There's minimal fatigue. The majority of patients wouldn't even relate that they have any fatigue or any other side effects other than you can see this little sunburn that's about the size of a nickel. And that sunburn eradicates itself in about 2 or 3 weeks' time, just like any sunburn would.
And I take it you have are these for a place where it's not flat?
Yes, in certain areas, nose, internal nose, lips. I mean, there's some areas where an applicator just doesn't work. I mean, eyelids where you're shielded. Right. And so you can create customized molds. And this is the same sort of thing where the catheter connects to here. The computer will put it anywhere in that where it specifies. These are all CAT scan-based planning, so we can see exactly where the radiation goes. You can see how deep it goes. You can control it very, very accurately. Right. And by doing that, we can accelerate the course. People didn't want to go through radiation in old times because it took 6-7 weeks to treat on daily aspect. These treatments on the head and neck are done in 10 3-minute sessions. Other areas in the body, you can do it in about 7 3-minute sessions. So it's something that it's convenient. It's easy. We don't even do them daily. We typically do 10 3-minute sessions every other day. They're done in 3 days in a week, and there's no change of their life other than I need them for about 20 minutes 3 times a week. Right. So it's a very novel therapy. We've been doing it for about 6 or 7 years. It's really not that new. It's just there's not a big public awareness of it. Even our referring doctors, the dermatologists, don't really understand the difference between a high-dose rate treatment and the old-fashioned electron treatments, where those were drawn out. They, again, treated much more normal tissue, caused much more side effects. But the vast majority of patients with any skin cancer in modern times can be treated with this simple system. Out of about 1,000 patients we've treated, I've only seen 1 recurrence. It was a marginal recurrence. It probably was something at the edge that wasn't even included in the radiation field. And out of about 1,000 patients, I've had 1 person that had a wound healing issue. It took her about 6 months to heal, but she's healed perfectly. It's uneventfully, and it's a very well-tolerated treatment that works well. There's just not enough public awareness that there's a non-surgical alternative.
So I'm going to go back to basic science for a second.
Sure thing.
Patients don't really know what radiation is. What is it that you're delivering down the shaft to this, to here, and then to the skin?
Radiation
what does it do?
Actually is a radio wave. Just like what goes into your phone or what you hear over the radio, it's just an exceptionally high frequency radio wave. that it'll actually penetrate the skin and it goes between cells. It actually goes into the nucleus and hits the DNA. It causes a water molecule to split. So you have a free radical. We've all heard about free radicals. We use antioxidants because that's scavenging these free radicals. But radiation actually treats by generating these and generating them within nanometers, so less than the width of a hair. And so it's a very precise where that free radical damages the DNA. It doesn't kill the cell right there. The cell is robust. It tries to repair this damage. When you walk out to your car, you get damaged DNA every time you see the sunlight. Your body will repair that, recognize it, repair it within 20 nanoseconds. Cancer cells, because the fact they became cancerous, it's the fact that that processing of looking at this repair wasn't recognized and it allowed it to mutate. That's how we select out those cells, is they cannot fix the damage of radiation. By doing frequent treatments, you eliminate those. That's how radiation works.
So is there any follow-up required when a patient is seen for this? What happens afterwards?
Typically, we do about a 3-week session. I see them about a month out. By that time, the skin is completely healed. They're back to their self, and then they resume normal surveillance with their dermatologist.
And during that time, is there any special care that they need to do for the site?
We just give some basically lotions, just good moisturizing creams. Radiation's a little bit drying in those areas, which will recover, and a good moisturizing cream will help you exfoliate. We're creatures that are meant to shed, so the more you use lotions, the healthier your skin is. And it just helps it exfoliate to get back to the normal healthy skins underneath.
And then there are 3 skin cancers that we think about: squamous cell, basal cell, and melanoma.
And there's actually a 4th that is becoming more prevalent called Merkel cell, and it's a different
Merkel cell?
skin. Yeah, it's definitely a different skin cancer. This is not for melanoma. Melanoma needs to be surgerized. It needs to be taken out.
This cannot be used for melanoma.
Yes, it's not the surgery is the dominant approach because of the resistance of those cells. But any basal cell, squamous cell, there's a small one called Kaposi sarcoma that is also amenable to this, as well as Merkel cell. The last 2 are very rare.
Do you use, other than for killing cancer cells, is there anything else radiation is used for in medicine?
Every blood that is given to patient is radiated. You can treat benign disease. Through history, we treated mastitis, acne. You know, now that we've got better medications, we used to treat rheumatoid or osteoarthritis, and it works well for that. It's a potent anti-inflammatory. But nowadays we have better medications, so we primarily focus on cancer.
Very good. We're glad to have you here this evening.
Thank you.
Very interesting. Thank you for coming.
We hope to have you back, and thank you for being with us this evening on Dialogue with the Doctor. And once again, we hope to have you back, because it was very interesting.
I appreciate it.